Hey, good morning, everyone. Today we have assembled here with Dr. Daver and Dr. Pemmaraju, who are very proficient in their work, have done a tremendous amount of work in progressing their own fields. And we are here on behalf of JIPO today to talk about the recently held American Society of Hematology meeting in December and to give an opinion about the fellows' perspective and the new exciting things in the field of leukemia. I'm Dr. Senapati. I'm a leukemia fellow at MD Anderson, and I feel honored to discuss today's morning's meet with Dr. Daver and Dr. Pemmaraju. Thank you for giving your precious time for this meet. So this year, ASH was pretty exciting, I must say, and with the hybrid format of the meet, a lot of us could actually participate and observe different meetings, which otherwise would have become difficult if it was in person. And we could also go back if we had missed some meeting and see that. So I asked a lot of my other colleagues as well. They were pretty happy with the way ASH was done this time. So obviously in COVID times, I presume this was the best way in which it could have been done. Now looking at all the interesting things that have been portrayed at ASH 2021, there are several new things in acute myeloid leukemia, myeloproliferative neoplasm, and Dr. Pemmaraju's favorite blastic plasmacytic dendritic cell neoplasm. So coming to you, Dr. Daver, there were several things on which you've been working on, and I would want to start and ask your opinion about immunotherapy in AML, especially the promising magrolimab trials. And this year, the azacitidine venetoclax magrolimab combination was presented also at ASH, and what your opinion and further promises in that field are.
Yeah, thank you very much, Dr. Senapati. So yeah, great intro. I agree. ASH was I think better than I expected. It went really well for those in person, those not in person, and a lot of interesting things happening in AML. As you said, really the theme is building combinations. I think for ASH this year was venetoclax backbone-based combos, whether it's with intensive chemo or the so-called triplets that MD Anderson we are heavily focusing on and think maybe the next step forward. And so one of those is, of course, in the most difficult molecular subset, not just in AML, but also in probably all malignancies, which is TP53. And as you said, CD47 antibodies in general, and magrolimab is probably clinically the one most advanced, have shown encouraging activity in combination with HMA in TP53 mutated AML. And so we developed a MD Anderson study, AZA, venetoclax, magrolimab, triple therapy. And the data we showed is early, but we are seeing very encouraging true CR rates, especially in the TP53 mutated AML patients with molecular clearance. And so we hope that this will translate into better transplant outcomes and better survival outcomes for this population. The true CR rate was 64% in the 25 frontline patients, including majority being TP53, which if you compare to HMA ven, the true CR rate is about 37 to 40%. So if that holds true, this is very encouraging. And actually based on this, there is a randomized phase 3 study that has been initiated across the world of AZA, venetoclax, magrolimab versus AZA, venetoclax, placebo for all frontline, older, unfit, high-risk sort of AML populations. Now, we have to be careful that, like with any new treatment, like venetoclax with TLS when it first came, or as Dr. Pemmaraju will discuss with tagraxofusp and CRS, or with CAR-Ts and cytokine release, you have to be aware of toxicities in magrolimab. And I think most other CD47s have what we call on-target anemia, which happens because red cells express CD47 at a high level and are cleared out usually during that first 3 to 5 day period. And I think we need to be careful as these studies expand to multiple sites, because if not managed well, this could cause problems. But actually, it's quite easy to manage if you check blood counts closely first 5 to 6 days. So hopefully we will see what happens with the randomized studies going forward. And I'll turn it back to you.
Yeah, that's brilliant to know. And it's very promising, very optimistic. And especially with the subset of TP53 mutated AML, which have traditionally done poorly with conventional chemotherapy, and even with BCL2 antagonists, looks like magrolimab can really open the box and take the avenue for success in the near future if things turn out well. Now, coming to venetoclax and combination regimen, there were data with the decitabine 10 days venetoclax in different subgroup of patients, and also the triplet combination as azacitidine, venetoclax, and gilteritinib in FLT3 mutated AML, and they all look pretty promising and doable, even outside the purview of clinical trial, probably once they get approved.
Yeah, Yeah, I'm going to start and I'm going to turn it over to Dr. Pemmaraju to give his thoughts. He's been very involved with these combos as well. So, as you know, Aza-Ven gives you a CR/CRI of about 65-70%, true CR about 40%, but median overall survival, especially in some of these difficult populations like FLT3, is only around 11-12 months. So we designed a strategy based on our previous combo, Venetoclax with gilteritinib, that's also, moving along nicely, that maybe we could do the triple therapy up front. And as you said, with early numbers, 15, 16 frontline patients, we're seeing close to 95% CR/CRI, with majority being true CRs. We do see prolonged myelosuppression as expected. You had a third drug. But actually, if you look at the total number of people recovering counts by day 45, 50, it's more because the CR rate is actually 90% compared to 40%. So I think going forward, the triplet for FLT3 especially, I think is one that I'm very, very encouraged and excited to see. But yeah, Dr. Pemmaraju, what are your thoughts?
Dr. Daver, I think this is a very exciting discussion and fully agree and support what you're saying. And you personally have been one of the world leaders in this area with our group. A couple points come to mind that came out of ASH and now as we go into 2022. Number one, as Dr. Daver mentioned, our field is at a crossroads, which is maximizing so-called sequential therapy. So individual agents, one after the other for a patient after they maximize therapy, versus going to doublet and triplet. And as Dr. Daver has shown and demonstrated repeatedly, there is a safety window that one can use. Oftentimes, optimizing, adjusting doses of if you were giving the agents in single agent versus in combination, and of course, learning on the job as you go. So the management of toxicities and also the management of what a course is. So we used to say 28 days is a course or a cycle of therapy in the old era, but maybe in the modern era, personalized therapy, a cycle for one patient, maybe 35 days, 42 days, 56 days. So that sort of stretching of the understanding. A second point is this concept of post-transplant maintenance. So you have a patient with a targeted molecular mutation, IDH, FLT3, for example, and what our group and others have shown is the feasibility, safety, and actually efficacy of delivering safely targeted therapy post-stem cell transplant. So looking at the transplant not as a one-stop shop, but as a part of the journey, I guess, of the AML patient where there is life, long life after the transplant and possibility to keep the remission there. And finally, as Dr. Daver mentioned, new drugs mean new hope, new avenues, but also awareness of new toxicities. So I think we have to keep that in mind, watching out for not only toxicity during our clinical trials, but post-marketing safety, which we're all very concerned with. But Dr. Daver, I was wondering what your take is sort of on those new areas that you yourself have pioneered.
Yeah, no, thank you very much. I think this is a great point, especially the change from the binary vision of AML, I would put it, as to whether you achieve CR or not. For 30 years, that was like it. If you didn't achieve CR, that's it, game over. To the more continuum total therapy approach of multiple myeloma, which has been very, very successful. And we personally, we meaning MD Anderson, myself, our vision is that AML can be converted to a chronic subacute disease. And that's our push. So instead of saying, let's put all our eggs in the high dose intensive front line, if the patient doesn't respond, it's over. Let's do HMA-VEN with whether IDH, FLT3, magrolimab, sequential versus upfront. I think that's something we still need to work out. Of course, there's benefits. You combine them, you get molecular clearance, but more toxicity. But then, like as you said, move to transplant, do maintenance post-transplant. If they relapse, then you have other targeted therapy, FLT3, IDH, and of course, immunotherapy will come in here. So I think in the next 5 to 10 year period, rather than hoping to find the silver bullet like we've done for the last 4 decades and have not been successful, can we use the drugs at our disposal in an optimal fashion to improve survival? I mean, if we can get from median survival of 15 months with 35% alive at 2 years in older AML to 55, 60% alive at 2 years, I think that's already great success rather than saying it's absolute yes or no. So I completely agree with you. And I think that's something in the near future. Not 20 years from now, hopefully we'll have CAR Ts and things like lymphoma where we can wipe out disease, but those are not on the horizon, are going to take a lot of work and may or may not pan out. So yeah.
Very interesting thoughts, Dr. Daver and Dr. Pemmaraju. And with the opening of the moonshot programs for curtailing deaths from cancer yesterday, these promises, I think, will really hold strong for the future. Coming to Dr. Pemmaraju regarding, you have done a lot of work for drug development in myeloproliferative neoplasms, and this year, Ash, there were many molecules beyond ruxolitinib and JAK inhibitors that seemed promising. I want to start with the PTG 300 that was fertile with a very novel mechanism of action, and your thoughts about that, and how do you think it's going to be for the future?
Yeah, excellent. Thank you, Dr. Senapati. So, just for everyone out there, MPN, so that's 0 to say 19% blast, and then 20% above would be this AML category. There's 3 different buckets now, which is amazing just in the last 5 years. So you have, as you said, JAK inhibitors, and now we have novel JAK inhibitors that are in the late stages of development. Then you have combination therapies. You keep the JAK inhibitor, add in the novel agent, and then you have completely novel agents that have nothing to do with JAK. So it's a completely exciting time for our patients. One such mechanism you bring up is the PTG 300, also now known as rusfertide. This is a very interesting new agent. It's called a hepcidin mimetic. So the goal overall is to try to restore the homeostasis or balance of iron metabolism in patients with polycythemia vera, where by definition that balance is abnormal and it's leading to too many red blood cells. So the one way to think of it is delivering a continuous phlebotomy for the patient without having to actually do the bloodletting. This is a very new agent. The encouraging data that we showed our group, multi-center group, in 2 separate oral presentations at ASH in one of the MPN sessions really shows 2 things. One, that this weekly injectable is safe, it's feasible. Many of the patients, the majority, are becoming phlebotomy free. And then 2, at the scientific level, correlatives, this purported pathway is actually being modulated, right? So in other words, the hypothesis is if you balance the iron metabolism, hepcidin, the hematocrit will come down and possibly symptoms can improve. And we are seeing that so far. So what do you do with this? It's an ongoing phase 2, early data, not yet approved for anything. And now it goes into the so-called phase 3 testing, global multi-center study to try to compare and validate these results in patients with polycythemia vera. Again, opening a brand new area of research and patient care in an area that hasn't really seen much innovation over the past 3 decades.
Absolutely, absolutely. And taking from where you said about adding on therapies to ruxolitinib to see changing the disease biology and how it can help patients, the area of BET inhibitors like pelabresib, that also seems promising, and we would really want to know your thoughts about that.
Yeah, you're really hitting on all the big points from ASH. That's correct. So in this combination category, there are 3 or 4 agents that have really moved to now phase 3 testing, and you mentioned one of them. So BET or bromodomain inhibitor, pelabresib, which is a very encouraging, promising program. Again, as you mentioned, these are patients who are myelofibrosis now on JAK inhibitor, ruxolitinib, failing, suboptimal response. You keep that agent on and then add in the This program started out in that suboptimal failure and then also has been tested as a single agent and now frontline combination versus ruxolitinib alone. So that's now heading into phase 3. Very excited our field is to see. In addition, you have the Venetoclax agent, which hits BCL-XL. So Venetoclax, which we mentioned earlier in AML, is BCL2 primarily. This one is the cousin pathway BCL-XL, same development pathway, suboptimal failure combination, single agent, and now frontline combination, phase 3 ongoing. And then finally, PI3 kinase inhibitors, so on and so forth. So you do have 3 or 4 separate classes of novel agents, not JAK inhibitor, combining with JAK inhibitor, first in the suboptimal or relapse setting, now moving into phase 2 and now phase 3 studies, into the frontline de novo untreated patient setting. Dr. Senapati, this is unprecedented for our field.
Brilliant. And it seems like there is a possibility that all these medications or neotherapies might change the natural course of disease once the data is out.
Well, again, I'd like to comment. You're exactly right. This is the hypothesis. This is the goal. For our viewers, we emphasize many of these things are investigational, promising, not yet approved. But as you said, the goal, the hope, not only in the laboratory, but for the patients, for our patients, can we modify the disease? What does that mean? So beyond spleen size reduction, can we improve overall survival for the patients? Can we decrease variant allele frequency, the burden of the disease at the molecular level. Can we modify the fibrosis in the bone marrow? Can we prevent the transformation to AML, post-MPN AML is still one of the most difficult areas. So yes, these are the questions that we're hoping to ask and answer in the coming years.
Brilliant, brilliant. However, amongst all these possible, positive outcomes, there still remains the group of patients post-myeloproliferative neoplasm who convert to acute myeloid leukemia, and it still seems like a very unmet need. There is data from ASH that shows that combination of BCL2 antagonists with hypomethylating agents, good response rates, but not significantly good survival. So Dr. Pemmaraju and Dr. Daver, where do you think this field is progressing of these extremely high-risk subset of patients?
Yeah, sure. I can start with that. I mean, that's probably the toughest group right now of patients, and part of that is because a lot of them are enriched for TP53 mutations. So we know a transformation from myelofibrosis to AML, the two most common mutations that are emergent or acquired are TP53 about 20% and IDH, interestingly, about 20-25%. And that's obviously quite important because we have now effective IDH inhibitors in combination with azacitidine. There was data at ASH, the Agile study, azacitidine looks very, very attractive. And I think a triple combo of AZA, IDH plus VEN that we have been doing, Dr. Leonardo and our group has shown some of the data already, is probably the way to go. And I think that's that one subset you don't want to miss, the MF transforming to AML with an IDH mutation. That's probably the only group where we're having decent outcomes. For everybody else, there's a lot of potential leads. BCL2, BCL-XL dual combination is of interest because BCL-XL plays a major role. MDM2 inhibition, which has been a very long and difficult field in general, AML, but maybe this is one of the specific groups. TP53, maybe the CD47 based therapies. So that's kind of what we're looking at. But I agree. I think Venetoclax, HMA, or intensive chemo based therapies, we've shown again and again, don't do much for this population. So we really have moved away from using those into one of these novel approaches. And Dr. Pemmaraju, your thoughts?
Yeah, it's a fantastic discussion. And just to add to Dr. Daver's nice comments, this has been a difficult area for just drug development, period. For example, the approved agent CPX-351 specifically actually did not include these exact patients that we're talking about. So it's commonly said, oh, it's secondary therapy-related AML, but those are primarily MDS to AML or in that category. So these post-MPN AML patients are often not included on some of these studies. In addition, some of these patients have so-called blasting off, so the white count may be very high, proliferative, and then stem cell transplant oftentimes is not an available option because patients are so ill, older. Exactly as you said, completely novel drug development. That's an urgent, unmet medical need area. I think also another concept for us is, as Dr. Daver said, trying to think about breaking down AML and these accelerated diseases into microscopic molecular subsets. That's where I think we've seen the success. Inversion 3 MECOM, that still has an unmet medical need, right? So Dr. Daver is working on a CD47 TP53. We have agents for IDH1 and 2, FLT3. But so if we can continue to break down AML, post-MDS AML, post-MPN AML, maybe into molecular subtypes, that may offer some clue moving forward.
Very true, very important as well, because these are the subset of patients on which the field has to also evolve, and that might also give us clues for therapy for other groups of AML patients. Now, coming to your most favorite area in which you're a world leader also, blastic plasmacytic dendritic cell neoplasm, there were some data on pediatric patients who received tagracofusp, as well as patients, cohorted based on their age and baseline disease involvement. And also your recent publication, though it was after ASH, about upfront hyper-CVAD based regimens for BPDCN, and your thoughts about that.
Yeah, so the field of BPDCN, blastic plasmacytoid dendritic cell neoplasm, is at an exciting point for our patients and research field. I think you hit nice. I think the three areas that we highlighted at ASH successfully, one is the pediatric experience. The agent tagracofusp, anti-CD123, actually is approved now 3 years ago for ages 2 and older, but the experience in the so-called real world setting has been somewhat limited. It's a rare disease, even among older patients, and even more rare among pediatrics. So it is good to see the uptake and use of the novel agent, focusing on the capillary leak syndrome as the primary and potentially lethal. So you're right. It was good to show that people are able to prescribe and use it, and there is a safety profile that can be attained with use of the novel agent. So let's continue to amass that data and see what are the molecular and characteristic differences between younger patients and older. Number two, novel ways of targeting CD123. Dr. Daver and I are leading the efforts with this new agent known as IMGN632 with the ImmunoGen company, if you will, a second generation or next generation CD123 targeting agent. What's encouraging so far there is as a monotherapy, single agent, IV, Q3 weeks, can be given as an outpatient, well tolerated, no capillary leak syndrome thus far, as we reported publicly. This agent is moving forward not only in relapse refractory setting on trial for patients with BPDCN. So that's very encouraging to follow that progress. And then finally, combinations. As we've always mentioned, I like Dr. Daver's analogy about multiple myeloma. We see the field of AML nicely moving there. And I envision also the BPDCN moving there, a complex, heterogeneous, deadly disease. Monotherapies offer a lot of hope for patients, particularly older and frail, but combination therapies likely may lead to longer term remissions in many patients. So you mentioned our data from the MD Anderson with hyper-CVAD Contargen regimen borrowed from ALL, which offers CNS-directed therapy, longer duration remissions, and then combining that, right, with CD123 therapy, BCL2, Venetoclax. So trying to go for sort of a total therapy, combination therapy approach that one day hopefully can eradicate CNS disease, MRD, and it maybe even eradicate the need for stem cell transplant, which again is not possible for many of these older frail patients. So yeah, thanks for highlighting that. I think we had very good showing with that data, and I'm proud to tell you that all of these programs are moving forward in 2022 for our patients.
Absolutely. Thank you, Dr. Pemmaraju. So a lot is happening in the field of leukemia, as we all know, but as Dr. Daver rightly mentioned, it's probably not the silver bullet, but small amounts of development over many years that will ultimately lead to the answer. Any concluding remarks from your ends about, where you see the field today at and how over the next 1 year the developments are going to be?
Well, I think 1 year is tough. I can say that 2 or 3 key things in AML, right, that we're excited about are the menin inhibitors. We'll talk about those, but those look like a new targeted therapy. Again, as Dr. Pemmaraju nicely said, for a very small but important molecular group of MLL rearranged. And, if we can get those patients from 10% 5-year survival to 50, 60%, like FLT3, outstanding. So that's important. CD47 for the TP53 and maybe for the others. And then, down the line, I think maybe not 1 year, but 3-4 years, more immune therapy, NK cell based, maybe the CAR Ts, although those have been challenging, and even other gamma delta T cells and other approaches, I think is, the future. The other nice thing is that, the FDA and the regulatory agencies, I think also are very much in tune and in agreement with that idea of there may not be a silver bullet, and there has not been for myeloma for many years now. In lymphoma, of course, CAR T cells may be meeting that analogy, but most times it's just incremental improvement. I think the FDA is very open to that kind of approach of slowly improving median survival and 3-5-year survival until we can find really breakthrough novel therapies. But yeah, there's, I think, a lot of exciting stuff still to come. And turning it over to Dr. Pemmaraju.
Gosh, that inspired me, your words. Yeah, this was an exciting discussion. I think to add to that, the 2 things, Dr. Senapati, that are coming out of Dr. Daver's and I, our drug development experiences. One is the renewed focus and attention on other things outside of complete remission. I loved what you said earlier. So, quality of life for the patients, durability of response, cytokines, correlatives, putting together a whole program for a patient, not only to understand drug X and how it's doing in the patient, but to really start to understand the disease biology, modulation of the patient's experience. It can really help you to understand an overall new agent in a rare disease and how a patient is doing, maybe explaining it beyond just the numbers. So I think that's important. We've learned that from the MPN experience. The second aspect is, keeping an eye out for combinations therapies that have a rational basis in the laboratory, watching out for how they pan out in the patients and learning how to adjust doses. So not have to be fixed to a certain dose just because that was the approved dose for the single agent. And And I feel that the AML field has really shown that very nicely, that you can flexibly move over time and really try to maximize the efficacy for the patient while decreasing the toxicity. These are exciting things to watch out for in the next 2 years.
Amazing. Thank you, Dr. Daver and Dr. Pemmaraju, for your time and your wonderful insights. There was so much happening in the field, and I hope by next ASH, we will have even better therapies. And over the next few years, as Dr. Daver pointed, immunotherapies and newer avenues of therapy will open up. And at the end, our patient should be the one who benefit from all of this. Thank you, everyone.
Thank you very much. Great job.
Thank you. Bye-bye.
Bye-bye.
Bye.